Good evening, everyone. Today, the topic is ABG analysis for the emergency physicians. As we all know, ABG comprises an essential tool in ED, and being proficient is going to save a lot of time in making a diagnosis and also to treat the patient effectively. So today's speaker is Dr. Bhavesh Javani, and he's working as associate professor and the Department of Emergency Medicine at NHLM Medical College, Ahmedabad, that is in Gujarat. So he was actually an internal medicine physician. Then he moved on to the emergency medicine side, not just into the academic EM, and he's also part of many publications. He's also very much interested in the research side. And we have already seen him during our journal club meetings previously. And it's a pleasure to have you back, Doctor. So you can just start sharing your screen.
Thank you, Dr. Naveen, and thank you, SEMI team, for giving me this opportunity again. Yes, I'm just starting with the screen sharing. Okay. Okay, I hope I am audible and my screen is shared. Can you see this first slide?
Yes, sir, Singh, you can go ahead. Is he online? Yeah, doctor, you are on mute. And we lost your screen sharing.
Okay. Okay, yeah. Okay, so I think now I'm audible and screen is shared, right?
Yes.
Yes, so this is the normal pH, 7.35 to 7.45. And it's very amazing that it stays in between normal range. If it is going below 7.35, we call it acidosis. And if it is going very much low, it is not compatible with life. So our body, God has created our body in a way that all compensation and all the things are always there to take care of the pH to be in this normal range. That is always amazing. I always tell my residents that this is a narrow range, only 7.35 to 7.45, 0.1 range, but it stays in this normal range. Whenever it goes below 7.35, it is acidosis or acidemia, and more than 7.45, it is alkalosis or alkalemia. Okay, so we'll be talking about certain salient features. Site is a radial artery, maybe brachial and femoral artery. There are many videos on YouTube where you can see how it is taken. So because of want of time, I'm going to touch upon that. Now, it is pre-heparinized ABG syringe is used, and the salient feature about this is that you should flush it with 0.5 ml of 1 in 1000 dilution of heparin. If you don't flush it and keep it inside, like say if you are still having 0.5 ml of heparin into the syringe, then it gets diluted. So do not leave excessive heparin in syringe. As you can see, if heparin is there, because of more volume, you are not flushing it out, there is dilutional effect, and that dilutional effect will decrease the bicap level and PCO2 level as well. So your reading will be not completely accurate. So always have a syringe that is 2 cc and have a blood volume 5 ml, flush the syringe, pre-heparinize and flush it completely. That's important thing. And always try that there are no bubbles inside, because as you can see, bubbles are there, then it increases PaO2 and decreases PCO2. So there shouldn't be any bubbles left. And cold chain should be maintained ideally if you are sending it somewhere outside. Generally, most of the ED setups are now having in-house or in ED itself ABG interpreter. It's not that important. Otherwise, you're going to send it somewhere else. You have to maintain the cold chain. Otherwise, you can see there are some variations. Okay, and patient should always write a bit history as well. Like patient is having fever, then you have to, interpret in that light. So it is important that you take ABG with proper syringe 2 ml, heparinized, and flush it, and then take half filled, take it, say if it is 2 ml syringe, then take it 1 ml. Then remove all the bubbles and send it preferably in a maintaining the cold chain. So that's how the ABG is to be taken, right? Now there is a compensation. As I said, God has created a nice mechanism to make the pH in very much normal range. How it happens? There are many buffering systems, and first and foremost is acid base. Acidosis is H plus ion, right? So an alkalosis is by HCO3 minus carboxylic acid. So you can see if H plus ion concentration is precisely regulated by different mechanisms. And first is bicarb buffer that immediately comes in action. Another is respiratory regulation. And third is renal regulation. So all these compensatory mechanism tries to keep the ABG in within very normal or narrow range, as you can see, 7.35 to 7.45. Now, okay, backup buffer system, whenever, acidosis is there, our body will try to, do more deep respiration. We call it an acidotic breathe and try to wash the CO2 out. So any patient of, acidosis will have, as you can see, I think, yeah, in the previous slide, okay, H plus ion will combine with HCO3, so it will make H2CO3, and that's how this bicarbonate buffer system works, right? And then H2CO3 is dissociated into CO2 and H2, and then CO2 is exhaled out. And to get the CO2 exhaled out, the person has to do, deep breathing. It is not rapid, but it is very deep, so that the CO2 is washed out. So that is the first mechanism of compensation, right? Like you can see over here. And because of that, there is acidotic breathing that we say. Second is respiratory. As I said, because whenever there is a rise in H plus ion, there is increase in the ventilation, and that leads to decrease in the PCO2. So always, whenever there is acidosis and pH is low, then it points towards more of metabolic acidosis. We'll see it in this later slides. Okay, then third compensation is renal mechanism. Renal is very interesting mechanism. Like, let me go back here. Yes, you can see it tries to maintain the pH within normal limit, because our all metabolism will produce acids, H plus ions, whether it's carbohydrates, lipid, or protein. Whatever metabolism goes in our body, that leads to acid generation, H plus ion. So this H plus ion has to be excreted through kidney, and for that, in distal convoluted tubule, there is a mechanism to excrete H plus ion as well as to reabsorb the bicarb. Apart from that, there are other buffer system in the kidney itself, like PO4 minus 2, phosphate and ammonia. So all these ultimately mechanisms are there to take care of the pH to be in very normal range. So because of want of time, we are not going to detail of that compensation, but yes, compensation first comes in place, and once it is exhausted, patient is really bad and we need to act fast. Acid-based disorder are like either it can be primary, like metabolic acidosis or respiratory acidosis, or metabolic alkalosis or respiratory alkalosis. They are primary disorders. Many times they are combined disorders. Whenever there's primary disorders, there is compensation. Our body tries to get everything to the normal. That's how our physiology works. And if there are more than one mechanism, say patient is pure decay, it is metabolic acidosis, right? Simple, give fluids, give insulin, patient is cured. But sometimes patient of decay might have pneumonia as well. That is the reason of patient going in decay. So this is mixed disorder. Likewise, there are some examples of triple disorder. Like in toxicology, you will come across many times salicylate poisoning, in which you will get triple disorders. So acid-based disorders are either primary, single disorder, or mixed disorders. It is very important. If it is primary disorder, it's easy to diagnose and treat. But in ICU setup particularly, you will see many mixed disorders. Like patient is given more diuretics, there is decreased fluid balance. All this leads to multiple kind of disorders. So it is combined disorder. But in ED, patient comes and you get a history of diabetes. You get a metabolic acidosis, and it is compensated. That means you are purely decay. It's easy to treat. Patient goes home maybe the next day. So ABG helps that way very much to ED physicians for differential diagnosis, even to prognostify or explain the patient relative that how much duration patient might have to stay back in the hospital. So ABG analysis is very important for all ED physicians. So for interpreting, we'll go next couple of slides later on stepwise approach. But for that, we need to know some normal values that you all know. pH is 7.35, 7.45. I repeatedly have said in this session that this is normal, wonderfully maintained pH. PCO2 is 35 to 45, and bicarb, it is very important. Bicarb is 22 to 30. Now PaO2, that is PO2, is 72 to 100. Right? So these are the normal values you are supposed to remember. Then the next step comes anion gap. So you are supposed to remember this 12 plus or minus 4. Right? So these are the figures. If you don't remember this, you cannot go for the next step of analysis. So always remember these magic figures, right? These numbers are very important. For PaO2, like I said, it is 72 to 104. It's a range that depending on the age. So normal is 109 minus 0.4 into the age. So that is the normal PaO2, right? And you want to maintain the PaO2 and FiO2 ratio to be normal. Otherwise, you know how we diagnose and how we differentiate ARDS or acute lung injury and all. We're not got go in detail about that, but PaO2 you should know. So these are the values, right? So normal value of PaO2 109 minus 0.4 into 8. Generally 80, we keep it around 80, but a patient is a 90 years of age, then it may be like 109 minus 25. So it will be around 70 likewise. Okay, so yes, this patient is 40 years old, male patient, so his PaO2 will be around 93 to be normal. So you have to decide whether you are happy with this PaO2 or not, or you want to say change the settings of your ventilator patient is on 20 to maintain this PaO2, because you want to maintain the oxygenation to be normal so that oxygen is delivered to all vital tissues and his metabolism is controlled. Okay, another thing, like there's a range, right? So you will be confused like at the time of interpretation which exact number you should take. So for that there is 0 point. So always consider PCO2 40 to be normal, 0 point for calculations, and PCO2 to be 24. So now onwards in this slide so as well, whenever we try to calculate the compensation, 0 point is bicarb 24 or PaCO2, that is PCO2 is 40. Now compensation, that is not that difficult, but residents many times get confused like which equation to be used. So for metabolic acidosis, like I have started with metabolic acidosis. This is the commonest thing you will come across in ED rather than mixed disorders or metabolic alkalosis and all. So we'll start with metabolic acidosis. So say pH is 7.35 and less because it is acidosis, right? Now we have to think whether the compensation is adequate or not. Body will try to start the compensation as soon as acidosis is there, right? So there are different things, says one and the same, but simple, the upper one is Winter's formula. Please remember that it's important for exam as well. They may ask you. So it is 1.5 in bicarb into bicarb plus 8 plus or minus 2. So let's say this example, say pH is 7.31, so it is acidosis. Now bicarb is 10, right? So the PCO2, if we put this number into this equation, PCO2 will be 98. PCO2 will be 25. Right? If you keep it 10 over here, then it's 15. So 15 plus 8, 23 plus or minus 2. So 21 to 25 will be the range. Can you see the whatever I write on the screen? Is it seen from that side?
Yes, sir, visible.
Yeah, so the range will be 21 to 25. So you can see here it is 25, right? So it is well compensated. So that's how you have to calculate by Winter's formula, or you can use the simple last one. Again, if you put the same number here, it will be 25. And that's what you are getting here. But ideally is Winter's formula. So always remember this for exam purpose as well, because you get a very pretty nice range. And if your PCO2, that is backup PCO2 is 25 like this, it is pure metabolic acidosis, because compensation is also good, right? So a patient history is the diabetes, and this kind of ABG is there. That means you are dealing with a single disorder, unless from otherwise mostly, and it is decay, and you can easily treat and send the patient home, maybe in a couple of days. So that's how ABG is wonderful, and that helps you. Now, if your readings, or if my PCO2 comes rather than 25, it comes 50, that means now my patient is not only having decay, but some other respiratory disorders may be. So it is multiple disorders. So now your things are getting complicated. Now this patient may need more investigation, further treatment, and may stay in your ICU for long, in your hospital for long. So you can explain the patient's prognosis or maybe length of stay as well. So that's how ABG is very important for all ED physicians. So first is metabolic acidosis. Always remember this Winter's formula. Then the respiratory acidosis, you will come across that, also very common in government hospital. We come across COPD, very frequent. So that's a chronic disorder. Then the compensation is for every increase in PaCO2, there is 0.4 millimoles per liter increase in the bicap. Or if it is acute disorder, 0.1. Right? So don't get confused. Simple, remember this 0.1 or 0.4 increase in bicap once PCO2 is rising. So let's see some example. Let's see. So this is the same example I gave you here. Now, okay. So it is a respiratory acidosis. Let's see this example. So pH is 7.31. Yes. So acidosis. Now bicap is not down. It is, what was our 0 point bicap was 24. So it is not down. So it is rather up. So generally pH is low and bicap is low, then it is metabolic base or metabolic acidosis. Here what happens, pH is low, less than 7.35. But bicap is on the contrary, more than the 0 point bicap, that is 24. So it is respiratory disorder. So now compensation point for every increase in the PaCO2, there should be increase in 0.1. So instead of say 30, it is 50. So 20 PaCO2 is increased. So it should be increased. So it is in the same direction, and compensation looks adequate. So this patient probably is dealing with pure respiratory acidosis, maybe COPD. Right? So that's how this helps you. For compensation is very important, and that helps you. Right? So it's a chronic disorder, so 0.4. So there are 20 into 0.4, so 5. So you can see from 24 plus 5, around 30. So it is 31. So it is pretty like compensating properly. So it looks like pure metabolic respiratory disorder. So history taking is important. So whenever you send ABG, first write history in the request form as well, right? So that's how we'll calculate for the respiratory acidosis. So now we have reached a junction where we know how to calculate compensation for metabolic acidosis, that you will come across very common, and the respiratory acidosis. Likewise, alkalosis is not that uncommon, but it is more common. You will come across in ICUs as well. So compensation here is 0.75 CO2 for 1 millimole equivalent of bicap. So only remember 0.75 for 1, and here for respiratory alkalosis 0.2 for 1. Right? So if you don't remember right now everything, don't worry. If you understood first two part, then this lecture will go very smoothly, and that's very commonly will come across, rather than this metabolic alkalosis, respiratory alkalosis. Yes, you will come across, but not that common. Right? So same way you have to apply the compensation equation. You have to remember your 0.75 and 0.2. Right? So don't worry if you're not recollecting everything right now, but at least remember the previous one, Winter's formula, that is this metabolic acidosis. And for respiratory, always remember this for chronic, and for acute 0.1. Right? This thing, okay, you will do practice and you will remember this metabolic alkalosis and respiratory later on, but don't worry about that. So respiratory alkalosis, these are the examples. Causes will not go obviously about that, but just like, pain, fever, anxiety, these things will come across very common in ICUs as well. So you will get a mixed disorders in those kind of setup. Some medicines also cause respiratory alkalosis, so it is very important again. That was about respiratory alkalosis. About metabolic, I will not go. I'm not going in detail about metabolic and respiratory alkalosis, their causes, their presentation, because our topic is analysis. Otherwise, there are many things like what are the symptoms. You can also look at the symptoms for differential diagnosis. That will help you as well. But because of want of time and for maintaining the continuity, we'll not talk about that. So I just keep those slides, right? But they are not completely not unimportant, right? Okay, so now comes very important step. Now we know something basics, like how to take ABG. All are ready. All students now will not make no mistake. As I understand, you will take proper series, proper amount of blood, proper cold chain and bubbles and all the things, right? Then you will apply all the compensatory formulas that you read, and then these things will help you now onwards. So that's a step-by approach. Now, certain things like ABG is authentic or not, we'll not talk about that. That's also very interesting. Those students who are interested in knowing that, they can email me directly, because there are certain things you can, by this complicated method, you can know whether this is authenticated or not. The authentic ABG is not. Sometimes, you will be confused whether it's venous or arterial and whether the machine is calibrated and all. So these equations help you. But that is not routinely done. And because of want of time, for diverse group, I'm just skipping this. But those who are interested in knowing this, they can mail me and I will send this them. Right? So, okay. So those slides are, I am skipping. So don't worry, that is only for knowing the consistency and accuracy of the recording. Right? Not the analysis, whether the ABG has been taken properly and machine is not. Then comes the steps, real steps, actual steps. So first is history. Don't forget, history and physical examinations are very important. 70% of diagnosis of any disease are arrived by proper history and physical examination. That is not my words, that's a word of Sir William Osler, who was the father of general medicine. So anyways, history and physical examination, first step. Consistency, as I said, we are not going to touch upon that. You can do it by the previous slide that I showed you. Then the pH. So acidosis or alkalosis. Then this thing is very important. Okay, let me just block this part. Okay, so now you have to see pH and then PaCO. If pH is going down, like 7.31 is going down, and PCO2 says 24, so it is also going down. Normally it's 30, 35. So it is metabolic. So first, if both the arrows are same way, it is metabolic. If one arrow is down, other arrow is up, then it is respiratory. Likewise, if both arrows are up, it is metabolic. But one arrow is up, one arrow is down, then it is respiratory. So that this example is say for metabolic acidosis like DK. This example is for like COPD. And these examples, okay, sorry. And these examples are for metabolic alkalosis and respiratory alkalosis. Any doubts? This is very important because after seeing pH, students are confused what to do. The second, immediately see PCO. If both are in the same direction, it is metabolic. If one is down, say pH is down, backup is up, that is respiratory. Now, third step is whether it's respiratory disorder, then it's chronic or acute. Again, that's by history only, but there are different methods. So I'm skipping this. This is a very different, complicated method by which you can know if it is acute or chronic. But okay, history is only enough. So we are not touching upon. So second step is compensation. Now the compensation is adequate or not adequate. That will help you, right? So this step is very important for compensation, right? Like for metabolic acidosis, if PCO2 is expected, like in our example, pH was 7.31, just recollect. So it was metabolic acidosis and PCO2 was 20. Bicap was 10, so PCO2 was around 25. So it was pure compensation. Right? Just example that we have started with. So I'm just continuing the same example. So compensation is adequate or not. If compensation is adequate, then you are happy. If it is not, then yes, it is mixed disorder. Likewise, in respiratory disorder, if compensation is good, like in our example of COPD, pH was 7.31, while BICAP was 31 higher side, so PCO2 was also 50. So compensation was adequate. So it was a pure, probably COPD kind of case. Otherwise, it's a mixed. So you have to apply and go further. Next step. Next step is if it is metabolic acidosis, something concept of anion gap. Generally, what happens, we don't measure all the things in our laboratory. So certain unmeasured anions and unmeasured cations are there. So the difference of unmeasured anions and cation is known as anion gap. Generally, we calculate it on the basis of our sodium, that is anion and potassium plus, and then deduct it by the sum of cations that are bicarb and chlorine. So this all you will get in a ABG report. In old machine, chloride was not many times available. You have to ask for, but now it is available in all the machines. So this is how anion gap is calculated. So plus ions minus total of minus ions. Normal value is 12 plus or minus 4. So it comes around 8 to 16. Right? Now there is some catch, like it has to be adjusted in the light of the albumin. Say if albumin is very less, it happens many times in ICUs. So albumin is 2.5 only. Like if you put albumin 2.5 over here, then it is 2. So 5. So observed anion gap plus 2.5. So if anion gap comes to around say 10 or say 13, then the actual will be 18. So it is high anion gap, right? So you have to adjust in the light of the albumin. It happens in ICU most of the time, like patient is very much hypoalbuminic, hypoproteinemic, and you have to calculate the anion gap and then correct it. That is adjusted anion gap, right? Because as you can see, 50% decrease in albumin will decrease 75% of the anion gap. You can imagine. So there is a big error in calculations of anion gap if you don't take in consideration this albumin level, right? So never forget. After ABG in ICUs particularly, see the albumin and correct it. Now that helps because if it is high anion gap metabolic acidosis, then causes are different. If it is normal anion gap acidosis, the causes are different. For high anion gap acidosis, metabolic acidosis, these are the common cause. And for residents to remember it, something like mud piles, that is methanol, uremic, DK, paraldehyde, isoniazid, lactic acid, ethanol, and salicylic. Just if you want to make it simple, common is DK, you will come across. Uremic, very common, dialysis patient, missed dialysis, sepsis, having ARF. So all these are uremic, they have a metabolic acidosis. Patient has got isoniazid now, and I am not that commonly coming. Lactic acidosis, ethanol or methanol. Methanol has got very resistance metabolic acidosis. In methanol, whatever bicarb, even if you replace, it's very difficult to control. In all huge tragedies or adulterated alcohol tragedies, you will come across metabolic acidosis. There is very much resistance. Whatever you do without dialysis, you cannot take care. But anyway, so that is the commonest cause of metabolic acidosis as well. So if you want to remember by this mnemonic, it is mud piles, or simply it is DK, uremia, methanol, ethanol, salicylates. Now there are certain conditions where anion gap is less than 6 and metabolic acidosis. Then the causes are plasma cell disorders and say bromide intoxication, not very common in our part of world, but say plasma cell disorders will come across. They are big list, but this is a common thing that will come across. I just narrated those things. Third is non-anion gap. That is very common and very important thing to remember, that many residents think that all DK, all metabolic acids are DK. No, all are high anion gap. No, there are many common causes of non-anion gap. That means anion gap is not more than say range of say 8 to 16 normal anion gap. So the commonest cause are diarrhea, then external pancreatic drainage, then certain post-operatively, like that jejunal loop kind of operation taking place, certain medicines, and this renal tubular acidosis. We have come across many cases of renal tubular acidosis leading to hypokalemic periodic paralysis. So by hypokalemic periodic paralysis, we could diagnose that this patient and the ABG, that patient was having acidosis, and then we have to find by other investigation whether it is proximal or distal renal tubular acidosis, and then we have to find the cause. The commonest cause we found was Zika syndrome, like dry eyes and also leopard dosing. But basically, yes, there are certain causes of non-anion gap metabolic acidosis as well. So remember those things as well. Or other drugs, many drugs as well. So what will you do for that mixed disorder? Or patient may have one cause of high anion gap and one cause of even normal anion gap metabolic acidosis. So next step comes very important, is known as delta gap or gap. Generally, okay, the anion gap is delta anion gap is measured anion gap minus normal gap. Normal is 12. If your measured comes to 13, that means it is 1. So this delta anion gap is say 1, and delta bicarb gap. You say it is also 1. That means the ratio is 1. So that is known as ratio of both the delta of anion and delta of bicarb. Say if it is more than normal, it should be 1, then it is pure high anion metabolic acidosis. Then it is decay, uremic, methanol, certain things. No chance whatsoever of any further disorders. But if there is more than 1, that is delta of anion gap is more than the delta of bicarb, then it is metabolic acidosis. Anion gap is associated with metabolic alkalosis. Right, so that makes our life now easy. We know that this patient has got metabolic acidosis with high anion gap, say 15. Delta gap is so the anion gap will be 3, and delta gap is also, if it is 3, then it is pure high anion gap. But say here it is 1, so the ratio is more than 1. So that will be associated metabolic alkalosis. Getting the point? So we have diagnosed a metabolic acidosis. We found the compensation. Say it was say undercompensated. Now you found the anion gap. Anion gap was say higher. So next step we will do, because patient is metabolic acidosis in high anion gap, compensation is not completely normal. So you have to go with one step further. That is this step, 6th step you can say, number in material, but this step is important. Then you have to find a gap. That is delta of anion gap divided by delta of bicarb. And if that is more than 1, then it is associated metabolic alkalosis. So now this patient has got, apart from say decay, some cause of metabolic alkalosis. Right? So you correct it and patient is cured up. Same time it can happen that this is less than 1. So the metabolic, anion gap is 3, but delta gap is say 6. Delta of bicarb. That means ratio is less than 1 of this anion gap versus bicarb gap. That is gap. So less than 1. Then it is associated with non-anion gap metabolic acidosis. So this patient of DKA is having a lot, maybe diarrhea, right? May have some other cause as well, like pancreatic drainage, maybe on magnesium sulfate drug, or maybe calcium chloride acidifying agent, certain things. Right, so I'm giving this, I'm jumping from slide to slide to make you appreciate that why this step is important as well, right? So now just make it again simple. Or my patient has got say anion gap of 16. So delta anion gap is now 16 minus 12, so 4. And his bicarb is say 20. So 30 minus 20 is 10. So 4 by 10, so less than 1. So this patient has got associated NAG, that is non-anion gap metabolic acidosis. So that's how this step helps you for diagnosing the mixed disorder. I hope you are not getting confused or things are not getting very much complicated, right? This step is last step, don't worry. If you are reached up to the previous step of anion gap, then also many things are covered. So if it is high anion gap acidosis, you know now certain causes. If it is non-anion gap, these are the causes. But if you want, like if you think depending on the compensation, that is a mixed disorder, then you have to go with the 6th step, and this is this. But above all, history is very important. Like patient has got, as I said, pneumonia as a cause of uncompensated diabetes control and decay, then you will get a mixed disorder. The patient is say on diabetic therapy, patient has some liver disorder and some pneumonia together, patient has salicylate poisoning, then the picture will be quite different and you can get more than 2 disorders together. They are known as triple disorders. So the first step in all is history taking. So always take a proper history and then interpret in the light of that history by these steps. Remember the compensation. Metabolic acidosis, Winter's formula. Respiratory acidosis, 10 for 2. Like 1 or 4. Likewise, acute or chronic. Metabolic alkalosis or respiratory alkalosis, 0.75 and 0.2. So there are only few numbers we are supposed to remember, but how to apply and interpret, that is important. Now let's take let's take this example. Okay, I think okay. So this is a case of Samsuddin, 62-year-old male, and this is his pH on 27th July 2011 in the morning, and you can see the pH is 7.2. So it is acidosis or alkalosis. If some resident wants to give me help, just if someone is there online and can tell me what is this, pH is 7.2. So it is acidosis or alkalosis. So it is acidosis. Then second step is PCO2. So it is going down, but PCO2 is high. So it is respiratory. Now see for the compensation. For every 10 increase in this, backup should increase. So likewise, it is respiratory acidosis, right? Because pH is going down and PCO2 is going up. Then step 3 was this acute and chronic, and then compensation. It's a chronic disorder, so 0.4 for every 1. So it was 50 PCO2. So backup should be around 21. It was at 40. Right. So likewise, it is compensated. Right. We can now see the ABG again, and you will appreciate. pH is how much? 7.18. It is acidosis or alkalosis.
They won't be able to answer via voice, but they are typing in the responses in chat box.
Okay, let me see. Yeah, so it is 7.18. So it is metabolic acidosis. Now we will apply the Winter's formula, right? This is a Winter's formula. So backup was 7.8. So it is applied here. So it comes to around 1.5 into 7.8 plus 8 plus or minus 2. So 17.2. Right. So next step is this is okay. The range has to be around 20. So it is good enough. So next step is anion gap. Anion gap is calculated by sodium divided by the cations total. So it is 140 minus this total of this. It comes down 30. So it is high anion gap. So it is high anion gap metabolic acidosis. So albumin was say low. So corrected albumin, corrected anion gap as per the albumin light is 35. So it is high anion gap metabolic acidosis. And history was itself saying patient was of CRF. Right? So that's how this helps us. Now further step is gap. That is, sorry. So 36 was anion gap minus 12 is normal. normal BICAP 24 minus here the measured value 7.8. So it is 1.48, so more than 1. So it is additional metabolic alkalosis. So you can see the history. Patient was having a lot vomiting as well, vomiting 10 to 15 times with decreasing. So that's how the patient has got metabolic acidosis, but because of vomiting, patient has got, say, associated disorder of okay, yeah. So the cause of iron gap compensated with metabolic alkalosis was vomiting, probably. So if you just can help the patient by stopping the vomiting, the cause of vomiting, then this probably going for normal and dialysis in patient is well off. So that's how this helps. There are many examples, but it is already 6:45. Let's take one more example. Say okay. So this is the sodium 140, potassium this much. I think the slide has been set down. Say this is the example. I think the slides have been a bit modified, but say this is the pH of 7.2, so metabolic acidosis. Now PCO2 is also going down, so it is metabolic acidosis, then metabolic acidosis, then this is anion gap is 15, so high anion gap, and then delta gap, and that is combined disorders. So this patient is probably having diarrhea and lactic acidosis because of decay and all. So basically, I think this slide has been modified a lot, but basically these are all examples for showing you. There are good examples given in Tintinelli and Harrison and other books as well, where you will realize how this all the exercise or jugglery of doing compensation and then anion gap and then delta gap helps. So these ABGs are important for all ER physician. Our ER specialty is quite different. We are getting acute patient. We need to give very fast answer to stabilize the patient and to transfer patient appropriately. So this ABG interpretation is very important. All residents of any caliber or any capacity should know ABG analysis. It is not that difficult, not so easy either. Only practice. Practice will make you perfect. So I wish you all the best to apply all the means that we have learned. I hope you have learned many things you might be knowing already. Many things might have been brushed up, and that will help you for day-to-day practice of ABG analysis tomorrow onwards. Thank you. Any questions?
Yes, sir. There were a couple of questions. One is, if I'm using a medical calculator, as most people have been using recently, then what should we pay attention to? If possible, can we take a discussion on this? There are some online calculators that will give you an idea on whether it's a kind of metabolic or respiratory. How trustworthy are those?
Yes, you can take help of medical calculator, but the steps remain same. Like because they don't know the history. Like say someone has given this example here 7.1, so it is, if you apply in the calculator some result will come, but here pH is 7.1, so it's not acidosis. PCO2 is going up, so it's respiratory. Then you see for the calculation compensation for every 10, okay, 55. Yes, so yeah, our question was calculators help, but you have to interpret in the light of history. Otherwise, this, like the example given, he has got mixed disorder, so you cannot, you may miss it. So this patient has got abdominal pain. Hello, am I audible now?
Yeah, you are audible.
Yeah, so yes, you can use a calculator, but without history, you may sometimes fall in a wrong direction. I think someone has put another some VRDS scope. Like whoever has put this pH of 7.1, let him interpret himself and what is his diagnosis.
Yeah, he's not online. So,
Okay, but yeah, so pH is acidosis, and as I said, second step is PCO2. PCO2 is going, so pH is going down and PCO2 is going up. So it is respiratory to start with. Then you see for the compensation. So from 35, it has gone 55 PCO2. So 20 PCO2 is rise. So backup will also rise by 2. So it is otherwise it has gone down. So it has got some metabolic disorder as well. So you can see it is lactic 7. So it is lactic disorder, lactic acid as well. Yes, so patient has zero sepsis, so that is leading to sepsis, and CKD is also there, but has got because of sepsis and some pneumonitis, maybe he has got this mixed picture disorder. So that's how it helps. So without history, I think still it is not possible to completely fathom exact cause and etiology. Any more questions?
no, that was it. Let me introduce the next week topic. So that will be data analytics in healthcare. And the
Okay.
speaker will be Dr. Danish Salim. He's a specialist and faculty at Sheikh Khalifa Medical City and also the HOD and academic director at PRS Hospital, Trivandrum.
Okay. Thank you very much for giving the opportunity, and we'll again meet next time with the data analysis.
Yeah, this ends the today's topic, ABG analysis for ER physicians. Thank you so much, Dr. Bhavesh Chavani, for coming over to the webinars. Even last time you have had a good participation because of you, and today we had great numbers, almost across about 100 people on Zoom, and by tomorrow we will be definitely clocking more than 1,000 views on Facebook as with each week. So if anyone wants to get notified about the future events, they can just contact me on WhatsApp. I'll be sharing my number on the chat box. I'll also share the.
Thank you, Dr. Bhavesh. It was very, very nice to see you and being a senior person and discussing so in depth about the ABG analysis, which is the most required for every emergency physician, as you are aware, because every diagnosis, what we do in emergency department, every prospects, or even after giving the treatment, after looking in related with sepsis, septic shock patients, or myocardial infarction patients, or any pulmonary patients. So any wide range, even the RTA patients also, we see the lactates and then decide what to do. In this way, you've made it so concise that our residents across the world who are viewing this program, this I'm sure that they'll be beneficial, and they will take home a lot of points which you have said, and they will implement it in the emergency department. Thank you very much.
Thank you, Dr. Srinath, for the opportunity, and nice to see you. Yeah. Thank you all. Keep learning. Bye.